We're back today again with the DisInformation Chronicle, and my guest today is Dr. Robert Redfield. He's a virologist, physician, and he's the former director of the CDC. Thanks for coming on, Bob.
Thanks for having me, Paul. Glad to be here.
So I want to talk a little bit about, you just have a book that came out. It's called Redfield's Warning, and you're kind of at a point in your career where you don't have to impress anyone anymore. You don't have next things you want to do. You've made your money. You can kind of do what you want to do. If you want to work, you can work. If you don't want to work, you don't have to work. And I read this book and it came across to me a bit as an autobiography almost, a look back at your entire career. What spurred you to write this book?
You know, Paul, I had a message I wanted to get out, and one that I feel very strongly about. As you know, I am a senior visiting fellow for the Heritage Foundation for Biosecurity and Public Health Policy. I'm very concerned about biosecurity. I actually think biosecurity is a greater national security threat than Russia, Iran, South Korea, or China. And I think our nation is totally unprepared from the biosecurity perspective. So part of the issue in Redfield's warning is to try to wake people up that we need to get prepared. And what I propose is that we develop a program in biosecurity that's proportional to the threat. And I think the threat is really real. And I think we should model it after what we've learned that was successful with the Defense Department, where we ended up developing a series of private sector contractors that played for the long haul. That's what we use in the Defense Department for our airplanes, missiles, bullets, ammunition, tanks, everything. That we do something parallel to that in the biosecurity business. I propose in the book that we ground it in the Department of Energy. They have a lot of experience in weapons of mass destruction. They already have 6 really great labs, so you don't have to, recreate anything. And they could easily manage a robust private sector contracting program that we could really stimulate. We are really way behind the 8 curve, Unfortunately, during the last administration, they put all their eggs in the vaccine business, and we really didn't invest, I think, heavily in the antiviral business. I'm a big advocate that it's the antivirals that are actually going to help us when we have the bird flu pandemic. The second reason I wrote the book was I was very saddened by the total loss of public trust that happened in public health from the time I was CDC director and then through the next several directors, that the public doesn't trust CDC or our public health community. And I thought if I could write a book and just be honest about the mistakes that we made and say, hey, wait, we made a mistake there. Hey, that was a mistake. Hey, vaccine mandates were a big mistake. Shutting down schools was a big mistake. That maybe it could begin to be a source of a dialogue to try to begin to rebuild public trust. And then the last reason was just to give the public a sort of a perspective on how these decisions are made, the complexity of taking science into public policy and making decisions. So that's why I did it. My wife asked me this morning when she knew I was doing this talk with you today, she said, are you happy that you wrote the book? Because sometimes it just brings criticism. And I said, no, I'm happy that I wrote the book. I got out there what I wanted to get out there. And hopefully we'll continue to stimulate the debate about biosecurity in particular and the importance of public trust.
So you go into sort of all the way back to the beginning of your career. You go over that. It was really interesting to me to read that because it brought back stuff from HIV and AIDS. And, I was a teenager at the time. And so it was just happening around me and you didn't really know of course we didn't really know what was going on. We just knew that these gay men were dying and, then you're someone like me, a teenager, and you're getting, you're reading what you're reading in the media, what you're seeing on CNN. You're not getting all the information. It was a very interesting time, but there was one passage you pointed out. I'm going to read this back to you. And you said, in several states, this is your personal experience, in several states, New York and California, for example, it was illegal to put a positive HIV test in a patient's medical records. That meant that an obstetrician could not tell the pediatrician delivering a baby that the woman giving birth had AIDS. I mean, it's just crazy for me to read that.
Yeah,
And there was so much craziness going on at the time.
It was true. It was that was in California in particular, and they enforced it. It was an offense if the physician did it. I was asked to do a consult on a husband of a dear friend of mine in New York City, that the African American, she was Caucasian, and they said, he came in and they said he had AIDS. And I noticed that he had a very high white count, over 25,000. And I said, I don't think you have AIDS. I have plenty of AIDS patients. They don't have white counts of 25,000. You said, what's the HIV test and what's the CD4 count? Oh, we're not allowed to have that in the Okay. Well, it turned out at the end of the day, I said, I think he has herpes encephalitis and you better treat him. And they eventually, after arguing with me for a day or so, treated him. And eventually they figured out after he got his AIDS test, the AIDS test could only be done in a single place called the AIDS Institute in New York. And once he eventually got it, it turned out, 2 weeks later, he's HIV negative. If you want anything more absurd in the state of New York, I was peripherally involved in this. There was an inmate who wanted to have his conjugal privileges with his spouse. But New York had a confidentiality law where the prison wasn't allowed to tell his spouse that he had HIV infection. On the other hand, the state had a law that you couldn't have conjugal visits if you have an active sexually transmitted disease.
Mm.
So the health commissioner of the state of New York, the city of New York, the CDC, they all testified under oath in this hearing that HIV was not a sexually transmitted disease, and therefore he should have his conjugal visits. There were some of us that took a different point of view, and I will say that the Supreme Court of the state of New York finally ruled on that case 5-4 that in the state of New York, contrary to what the health department said, they defined it as a sexually transmitted disease, and they denied him his conjugal rights. But that's how ludicrous these policies were at the time. So when we look at the COVID pandemic, where we've had some pretty unfortunate policies, like
Right.
vaccine mandates, closing schools, closing our economy, we have a tendency to develop irrational policies when we have a new public health problem. We sure did it for AIDS.
Right. So that was one of the interesting things is your expertise comes back from AIDS. One of the criticisms I've heard from a lot of experts in respiratory viruses is that's the whole problem that we had with the COVID pandemic. We had Fauci comes from AIDS, Walensky's from AIDS. All these people took lessons from AIDS, right? And then tried to apply it to a respiratory virus, which has a totally different epidemiology. It's like you're taking some guy and, well, he built a great Porsche. Let's hire him to build a dump truck for us. How do you explain that?
Well, I don't really know. I mean, clearly, many of us that were in public health leadership during the COVID pandemic grew up during the AIDS epidemic. And there were a lot of mistakes made in AIDS policy, which I try to point out in my book. As a point that I try to raise, there's nothing wrong with being wrong
Right.
in science or public policy. That's the whole scientific method. You have a hypothesis, you put it out there. And I always tell people, if you prove me right, I don't like you as much as if you prove me wrong. Because if you prove me wrong, you taught me something. And that's what science is supposed to be like. Unfortunately, in the modern era, it's is if you're incorrect, there's something, that you can't do that. That's a defect. And that was one of the big problems with the COVID pandemic is people didn't allow honest debate, transparency. They came up with a single narrative. You either bought into the narrative or you were discarded, or in like cases like myself, you were called a conspirator or racist because somehow I believed that the COVID pandemic came from a laboratory through gain of function research. And the narrative that was pontificated from high was that this came from a wet market.
Right. I want to go back into the history of the CDC, which I thought was interesting. You write about it a little bit. Originally, the War Department, it was called the War Department back then.
Yep.
Then
We're finally back.
Here we are. We gotten full circle on it again. It was the Office of Malaria Control and War Areas, the MCWA. This was during World War II in Atlanta, Georgia. And then after the war, when they were treating all these soldiers coming back with weird diseases, which I was a soldier, I went over to the Middle East, got all these vaccines. I don't even know what they were because there were all these diseases we were worried about. This always happens when we send guys abroad to fight wars. They get all these weird diseases coming back. So then they turned it into the Civilian Communicable Disease Center, and then it's been growing from there. What this, I don't really know if people understand exactly what the CDC is. I mean, we have the current HHS secretary has basically gone through there with a pickaxe at it, but what was it really designed to do?
Well, originally it was designed, as you pointed out, it was designed to help the Defense Department figure out how to keep soldiers protected, particularly against malaria. And the reason that it was developed in Atlanta, Georgia in 1945, 46, 47, 48, 49 We didn't have malaria in Washington, D.C., but
Okay.
believe it or not, we had malaria in Atlanta.
Okay.
And that's why they set up the whole system down there in Atlanta in the South, because we still had significant malaria transmission. And gradually, then Congress decided to pass a law to establish CDC, independent of the Defense Department. And it started as a center of disease control, a single center to control disease, focused on infectious disease and pandemics. And what happened over the next 40 years is it grew in its public health role. And one of the areas that um, I would have to say, when I was the CDC director, now it was the centers of disease control. They
Right.
had they had multiple centers. And I would say when I took over CDC, probably 60 or 70% of its effort was in non-communicable disease, chronic disease, seat belts, drug addiction, maternal child health. I mean, these are important public health tools, but CDC's, I think, primary mission really was supposed to be pandemic preparedness and pandemic response, epidemic response. And so I've been an advocate, for CDC to get back to its primary mission, which is pandemic preparedness and public health response. And then I think Kennedy will move a lot of the chronic disease roles that CDC was doing it. He'll move that into a new entity that he's building within the Department of HHS to go after chronic disease. It's not like he's getting rid of it. I mean, the media will say he's getting rid of it. No, he's
Right.
not getting rid of it. He's just moving it and trying to get CDC to refocus its energy on public health response. I'll argue that it's morphed not into a public health response agency. I give the example when I was there I came down in March. In April, I had my first briefing on opioids deaths because it was a big deal that year. We lost 80,000 people. Priority for the president, and I wanted to know, what are we doing about it? I had a briefing. It was a great briefing by the experts, and they really are high quality people at CDC. And when the briefing was over, I asked for what the data was through. And they told me the data was through March 2015. I said, but it's April 2018. And they said, yeah, Director, you don't understand the complexity that we have in trying to get data from the states. And I said, no, what I don't understand is I thought I came down here to make a public health impact on the health of our nation. And you're telling me what I came down to be was a medical historian. All
Right.
right. We've got to get real-time data. And we saw it during the COVID pandemic. CDC could not capture real-time data. And it's very hard to have a public health response if you don't have real-time data. I used to be embarrassed as a CDC director because I used to rely on Johns Hopkins dashboard to get my most up-to-date data on the pandemic. No,
Right.
CDC should have that. So CDC needs to, refocus its energy and make sure it has real-time data capacity across the nation. First and foremost, it's got to build its laboratory capacity to facilitate diagnosis of new pathogens. And then it has to build a public health response army. Now, I had some states when the COVID pandemic happened, they had less than 50 people in their state to orchestrate their public health response.
So that brings up one interesting issue. Early on in the pandemic, in the first few months, there were a group of reporters I'm pretty sure it was ProPublica, who they'd gone to a conference, came back, they realized they'd been exposed to the COVID virus. And they did a whole story about how long were they supposed to quarantine. They got one bit of information from the CDC, one from their local, one from the state. And I'm looking at this. Quarantine comes all the way from what? It's Italy back in the 1600s. It's an Italian word. And why did our country why did we not have protocols for quarantine? I would think that would have been something we would have had. It's a pretty simple thing.
Well, not only did we not have protocols, we didn't really have the capacity. CDC spent a significant amount of money, I want to say about $600 million, to build quarantine capacity within the states and develop our quarantine system. But when I had to pull the trigger, because we had our first 14 cases in the United States that I diagnosed, all of which had come back from China, and I wanted to evaluate their partners, and we had about 600 people exposed, 800 people exposed. But we wanted to do it where we had contact tracing and isolation, i.e. quarantine. There were no quarantine centers. We didn't have them. The states didn't use the money to build quarantine capacity. And when I brought back the U.S. personnel that were stationed in Wuhan, China, the State Department brought them back. They were in charge of that. They did that their own way. But when they hit the United States, CDC took over and quarantined them. And the only way I could get the quarantine done in the U.S. is reached out to the Defense Department and asked the Defense Department to partner with us. And we opened a number of bases in California and in Texas and Georgia where we actually quarantined people
Mm.
in military bases. And we did that probably pretty much for, I think they were quarantined close for 21 days or so. And we tested them in order to let them be dequarantined. Okay. They had to be test negative 48 hours and they could go. I know in Texas, unfortunately, one of the patients was told that they were now antigen negative, only for us to let them go. And the second test came back antigen positive. And then we had to track them down. They were at the airport. Governor Abbott was quite angry at me, because we had a big hoopla trying to track this individual down and get him back in quarantine. COVID is relatively pretty infectious. I consider it the second most infectious human virus that I know of, behind measles. It was that characteristic that made me pretty convinced from the beginning that this was a laboratory-oriented virus that was taught how to go human to human, because SARS and MERS, which were the predecessor coronaviruses, they didn't ever really learn how to efficiently go human to human. And even today, SARS from 2002, 2003, when it went from a bat to a civet cat to humans, now we're, go forward 23, 24 years, we still have had less than 10,000 cases in the world. And MERS is very similar.
Right.
10,000 cases in the world. And yet COVID, I had hundreds of thousands of cases in the Wuhan, China area almost overnight. It was a very
Right.
infectious virus, so it was organized to be infectious. But we never operationalized in a meaningful way quarantine. We did have multi-drug resistant tuberculosis that tried to keep a little of it alive, but the reality is we didn't have the capacity. And then when it came to public health case finders that could do a case finding, identification, isolation, most states didn't have those people either. We were totally unprepared.
So right now we're in the middle of the flu season, and that is now all over the news right now because Kennedy just come out. There's researchers I know who are they just got emails from the Washington Post. There's a Cochrane review that's a review of multiple reviews that found there's no real evidence that the flu vaccine helps for morbidity, mortality, or transmission. There's a recent study out from the Cleveland Clinic that found if you got the flu vaccine, actually more likely to have gotten the flu. Now, I didn't understand how this worked. And then I called up a respiratory virus expert who explained it to me that what's probably had happened is these people got the flu vaccine, and then until you get some immunity built up, which is probably about a month, in that interim time, if you're exposed to the actual virus, the vaccine causes your lymphocytes to fall, so you're at increased risk of getting any type of respiratory virus, and so that's when you get hit in that window period time. What's your overall thing on the flu vaccine? Because it's a huge contentious issue right now in America.
Yeah, I think, a couple things about the flu vaccine. First, I think it's not a very good vaccine, right? All things being equal. And we've had it for, 30, 40, 50 years. And a good year with a pretty perfect match for the circulating strain, the flu vaccine and the people that take it probably works half the time on a good year. My first year as CDC director, it probably worked 25% of the time. So that means that 75% of the people who got the flu vaccine got flu, right?
Right.
And that's what has hurt the American public's view of vaccination because, oh, yeah, I know, I took the vaccine and guess what happened? I got flu. Now, I think there are some exceptions to that. When I was a CDC director the first year, it was a very difficult reality as more children died of flu than any other year in the history of our nation. And when I looked into what those children had in common, because flu can kill children, unlike COVID, which is really a disease that causes death in those of us over 65, flu is an equal opportunity virus, that it can kill you if you're 1 year old, it can kill you if you're 10 years old, it can kill you if you're 30 years old, it can kill you if you're 60 years old. So when I looked at the deaths from flu in children, I found out they had one thing in common. None of them were vaccinated. So I'm of the view that vaccine may modify the possibility of death, that I see people who've been vaccinated for flu and get sick, they have a tendency not to die, all right? And people who get flu, get sick, and die have a tendency not to have been vaccinated. I don't think the flu vaccine's a good vaccine. I happen to be an advocate, and I'm involved in a publicly traded company right now that's trying to develop a better flu drug. We're trying to do it originally for bird flu because I think we need to have some medicines for bird flu, but it will also work for flu. And it has the potential because it's a drug that you might be able to take once a month, once every 3 weeks, once every month, that it could be a strategy for what I call chemoprophylaxis, which I think would work in everybody. The problem again with the flu vaccines, they have a disproportionate reality of not working in the people that need the most,
Mm.
people that are immunosuppressed or older, they need the most. Your concept is not unreasonable that when you do get a flu vaccine, you may develop a transient lymphopenia. That lymphopenia may have a consequence, if you're exposed to flu. I don't know for certain. I think it's speculative, but I think there's some science that can be behind it. I really think I'd like to see us move away from the flu vaccine and move towards chemoprophylaxis for flu.
Well, that's what the respiratory virus doctor that I spoke to, actually, that's what he actually told me. He's like, I don't know what the mechanism for this is, but I think this is what's probably going on. That's what he
Well,
said. The mechanism of this happening, of why do you get the flu vaccine, you get flu. He's like, this is probably might be what's happening. But he said there's no mechanism of action to explain it all. So
I'm a
one of
physician. I still practice. 2 days a week, and I still do recommend the flu vaccine. I do not try to kid people that the flu vaccine is a get out of jail free card. Because, as I said, just because you got the flu vaccine, it doesn't mean you're not going to get flu. I do think it means you're probably not going to die from flu.
Okay. Here's one section of your book which caught my attention because the mask thing was a huge deal. It's coming back right now. There's mask recommendations happening in all the places you expect. Cities in California, of course, New York. While the mask wouldn't stop every particle, it would greatly decrease the amount going into the air that could potentially infect others. But we had no evidence showing that wearing a mask would help non-infected people from becoming infected. Now, what's interesting about that is when you said so the first year of the pandemic, I just wore a mask, but I kept bumping into experts telling me there's no real evidence that they work. I went back and looked, and we find that Tony Fauci did a 180 where he said there's an email where he was telling the former HHS director, they don't really stop you from getting sick. They might help from spreading the virus, but they don't worry about having masks. So and then he did a 180. Then he turned around and said, wear masks. The 180, Theresa Tam, the expert Canada's expert, did the same thing. Then you've got Dr. Jenny Harries in the UK. She did the full 360 where she first came out of the pandemic and said, masks don't really work. Then she said, you got a mask. Then when they had their COVID investigation through the UK Parliament, she come around and said, well, there's no real evidence that masks work. I really don't understand this whole thing. And I went back and looked, the WHO's pandemic policy planning document, right, that was put out in 2019, it said masks have at best a small effect on influenza transmission. That's right out of their pandemic policy planning document from 2019. We then got the Cochrane review that's never found any evidence that masks work. What happened during the pandemic that these
Well,
masks became this? I don't get
happened.
it.
A couple of things happened, which I'm disappointed by, because I think one of the most famous answers to a question that I used to give when people would ask me, I would say, I don't know. And
Right.
people would get upset with me. They said, well, you can't say that, Bob. You're the CDC director. Tony would get upset with me. What Tony did originally was there was a shortage of masks for hospital workers.
Right.
And so they decided to tell the public that there was no need to wear masks because they wanted to keep the mask for the high-risk essential hospital workers. So in other words, it was sort of a political statement, not a scientific statement. All right. And then obviously we started to get masks into the system. People started looking at it. We started with maybe making your own cloth mask, which I and others in the Surgeon General helped demonstrate. The reality is those masks didn't really work. There was no real good science supporting the mask, as you know. And eventually they got to an important distinction between, was a mask going to prevent me from getting infected, or was a mask going to make me less infectious to you? And we did have data, and CDC had some of the data. We did have data that mask would decrease the inoculum that an infected individual had in a room. And we had these studies where we had these fake, groups that would cough. They weren't human beings. They were, experiments. And then we'd measure the viral particles and how far they go. And we were able to show that obviously masks reduce the amount of viral particles that would get in the atmosphere. We were also showed that humidity would do that too. I mean, there were a lot of other things that would do that. We were never able to show, to convince me that masks significantly decreased when I'm exposed that I'd get infected. What happened with the policy with masks, though, was once we learned, unfortunately, with the Diamond Princess, that what George Gow had told me was incorrect, was he had told me that they didn't have any asymptomatic infection. Well, the Diamond Princess came, and the Japanese allowed CDC to come help them evaluate it. And one of the first things we learned was a majority of people on the ship that had COVID were asymptomatic.
This was the cruise ship that became a big deal in 2020.
In Japan, that's right. And so now we knew that we couldn't tell who was infected and who wasn't infected, right? Because asymptomatic. So then what happened is when we told people that were infected to wear a mask, now since we knew couldn't tell whether you were infected
Right.
or not, then it expanded to just telling people to wear masks. But it was never really, in my view, to prevent you from getting infected. It was a strategy to try to decrease whether you would infect others. Now, the number one thing we tried to teach, if you're sick, do us all a favor and stay home.
Right.
The problem was once we learned that asymptomatic infection was really very common, probably close to half the infections, well, those people weren't going to stay home. And so that's where the masking came on as a strategy. It wasn't an effective strategy. It didn't work. It shouldn't have been mandated. You've seen some of the studies. You can go both ways. I think in Kansas, there's a couple studies that I think are reasonable that NIH did, which the counties that mask had, 25% less infections than the counties that didn't. You had the comparison between New York City and Hong Kong based on mass usage and what happened to transmission. But the truth is, I think the data at best I don't personally wear a mask at all anymore. And what I do try to teach people, if you're sick, stay home.
Right. I want to talk to you, since you ran the CDC, about pretty famous publication they put out, which most Americans don't know about it, but anyone inside public health does. It's called Morbidity and Mortality Weekly Report, MMWR. It puts out a lot of different issues. It's issued by the CDC, but it's not peer reviewed and it's not independent. I mean, I pulled down what it is, and it says right in there, by the time a report appears in MMWR, it reflects or is consistent with CDC policy. It's essentially a press release emphasizing what the CDC policy is, with people inside the CDC choosing what they are or not going to publish based upon what they want the policy to be. How can you trust what MMWR is publishing? I mean, it seems to be
Well,
just
it is independent in this. It has an editor. You're right that editor is a CDC employee, and it does have an editorial board, and some of the people on that board are CDC employees, some are outside scientists. The CDC director really does not influence the content. I know this personally because I was pressured under several occasions, I talk about it in the book, by the Secretary of Health to change the MMWR. And I told him it's not going to happen on my watch. I said it's an independent publication within CDC, okay? And the director was not going to dictate its contents. It is got an independent editor within CDC, although that person is an employee of CDC. The CDC director and the Secretary of Health have no publication influence on it. And it has a review committee, which includes CDC personnel and outside of CDC personnel. And I tried to maintain its independence when I was the CDC director. There's some sections in the book where I talk about some pretty heated discussions I had with the Secretary of Health, where I was being told to change the MMWR, and I just told him it's not going to happen on my watch, and if he wants that, he needs another director.
So during the Biden administration, the CDC website promoted N95 masks. So we went through this whole thing. I went back and looked at it. There was the cloth masks. There's the famous Surgeon General Jerome Adams showing you how to make a mask
Make a cloth mask. Jerome show you on TV how to make your own cloth mask
out of a T-shirt.
Yeah.
And then we went to surgical masks work. And then it was like, oh, now you need an N95. And the CDC's website began promoting N95 masks. Well, I dug around, which I'm I do these things. And I found out that the CDC had published a 2023 meta analysis that found no difference between 95s and surgical masks. And that's their meta analysis. But there are also at least two randomized controlled clinical trials that also found no separation between surgical masks and why?
There's some caveats that I don't think have been answered in those studies. The first is, in order for a 95 mask to work, it has to be properly fitted.
Right.
And as my daughter-in-law showed, even in a great hospital like University of San Francisco, a majority of the people really didn't have them fitted properly, right?
So this was a study. Actually, you sent this to me when it came out. It was your daughter-in-law. It was a study that looked at. It was really interesting. I looked at it very carefully. It looked at physicians. I'm sorry, healthcare workers who had been properly fitted. So they've been fitted with an N95 mask. They wore their properly fitted N95 mask, and then it found that like by the end of an eight-hour shift, like something like 30-something% of them failed. And
That's
these are
right.
people. This is not my mom putting on a mask and going to
There's two
Home
things that
Depot.
is important. So first, it has to be properly fitted, which in many institutions it's not. Secondly, there can be no facial hair,
Right,
which a lot of times is a problem. Secondly, it shouldn't be reused.
right,
And thirdly, as you point out, it has a half-life of being effective. As you
right,
get moisture in it, it doesn't work. And so
right.
the manner in which these masks have been used is not operationalized for the manner in which they work. So that's why when you do these comparatives, meta-analysis, I think it's hard. Does an N95 mask work if you use a new mask that's properly fitted and you change it every 3 hours? Yeah, it probably works. Does an N95 mask work if you have a beard? No. Does it work if you wear it for an 8-hour shift? Probably not. But I haven't seen a study that really looks at trying to look at the integrity of the mask as opposed to how it's used from a policy perspective. I think if you're really going to use 95 mask, you're looking at properly fitted mask, you're looking at no facial hair, and you're looking at probably an effective half-life of less than 3 hours.
Here's a portion from your book. Before becoming CDC director, I didn't realize how closely I would work with our intelligence agencies and how much highly classified information I would have access to. Someone who's spent a couple decades now looking at corruption in science and medicine, most of what I do, it's based on documents. And once you get into this intelligence field, there aren't really the documents. You're just calling people up when they're telling you things, which was very hard for me during COVID because it made it very hard for me when you started interfacing with this national security, CIA, State Department stuff. It made it very hard for me, maybe very uncomfortable as a reporter to cover this kind of stuff. What level security clearance do you have?
I was a top secret with SSI and compartmentalized probably almost every high classified compartment. There's 3 people in the HHS that had the highest compartmental exposure. So the secretary, Bob Cadillac, and myself. All right. So as you know, you have top secret security clearance. And then after that, there's compartments where
Right.
you may be entered into a certain document, but that's it. And then
Right.
another compartment, and another compartment. I was pretty much into any of the HS classified, and you also know that many of these are classified by agency. So
Right.
the documents that were in HHS that were top secret and SSI compartmentalized, I probably got into. I mean, I had to read, and that's why when I talk, I'm always careful about talking about the declassified information, since all of the information, unfortunately, Paul, despite being passed by Congress to be declassified, all of it still hasn't been declassified.
Well, that was going to be my question here. So I know that there's a skiff over in the Senate where there's a bunch of documents that a senator has access to, all classified material that shows, and what all those documents show is they all point in the direction of a lab accident. Now, the person who told me about this can't tell me what the documents, what they say, but this person told me the same thing too. They're like, I saw what was declassified under President Biden. I know what I've seen that's classified. There's stuff that I've seen that's classified that I don't see now declassified. And I've heard this from at least 2 other people. Is that your read on it too? Are there
Yeah,
documents?
there's definitely data, and we talked about that. I think just the other day, I did a talk at the Heritage Foundation. We were talking about, they talked about my book, and then we had a panel afterwards with some really good Ebright and Aline Chen and Congressman from Iowa on the gain of function research. It was just reiterated there's some very important classified data that would allow the American public to have a much clearer understanding of why people like me are so certain that this virus came from a lab that unfortunately, despite Congress saying everything should be declassified, still hasn't been declassified.
Now, the current CIA director, when he said last year, I believe, and also during his confirmation hearing, that he was gonna anything that involved the origin of the virus, he was gonna declassify. That hasn't happened. Do you know what's holding that up?
No, I don't know. I know John very well at Radcliffe. I have enormous respect for him. I worked with him. He was the chairman of a panel that we had for the Heritage Foundation working group to look at holding China accountable for not adhering to the international health regulation, which we finally concluded they cost the United States about, not to mention the 1,000,002 lives and more. We're still losing, last time I looked, we're losing 285 people a day. And that will continue going on for until we get the antivirals developed that we need. He told me that he thought this would be declassified. First thing he told me is that all the agencies will be revising their analysis, and pretty confident that they all would come to the conclusion like the Energy Department and the FBI did. The only one I've seen is the Defense Department's redone theirs and CIA, and they both come back now and said it came from the lab. But I haven't seen everything declassified, and the only thing I can think of, and I don't know the answer, but I do think that the intelligence community are probably trying to protect sources, because my own instincts are they're highly infiltrated into those laboratories in terms of human intelligence. But I don't know the answer. But it was clear to me, looking at this scientifically and reviewing the classified data that I got to review, that there's only one conclusion about the origins of COVID, and that is that it came from the lab. It came from gain of function research. And I do think the American public would benefit from putting that baby to rest,
Right.
because there still are people that want to say, oh, no, it came from, the wet market. It didn't come from the wet market.
So
It
back
came
in
from the lab.
2021, you went on CNN with Sanjay Gupta, and you said exactly this, that, from what you'd seen, your understanding as a virologist, former head of the CDC, this was, under the Biden administration, so you'd left the CDC, a guy with a TS, that you thought this thing came from a lab, and you're immediately just attacked by Laura Helmuth, who at the time was editor-in-chief of Scientific American. She said Robert Redfield shared the conspiracy theory that the virus came from the Wuhan lab, and she said Redfield is not an authority on the science. And then she sicked her deputy, Josh Fishman, on you. And he wrote this long piece calling what you had said on CNN was evidence-free. I mean, at the time when this happened, I didn't really know who you were. I wasn't really paying attention. It was in retrospect when I went back and looked, and I said, wait, this guy's a virologist. He is an expert. He ran the CDC, and he has a top secret security clearance. Like, this is the guy you'd want to go to if you want to know how a pandemic possibly started, if there's something being hidden. How did you deal with that at the time? And first off, what do you think about that this happened, that Scientific American, I believe it's the oldest magazine in the United States, attacked you in this way?
Well, first you see that there was a conspiracy here, but the conspiracy was the scientific community to try to negate people like me and stop discussions. Fortunately, Collins and Fauci had made the decision that there was only one explanation that was going to be considered for the origin of the virus, and that was natural spillover. And as you know, you can go back and look at the phone call they had in February 1st and all the arm twisting that went on. I wasn't on that call. And again, I try to make sure the record's correct. Some people said I said Fauci excluded me from that call. And I said, that's not what I said before Congress. What I said under oath was Fauci didn't include me. There's a difference, but he didn't include me. And he knew my opinion was that I thought this was lab origin. And I really did have a lot of evidence to support my opinion. It's not like just an opinion, not the least of which was a paper published in 2014, 2015, paid for by Fauci's group to the Wuhan lab that successfully got coronaviruses to infect humanized mice. So they actually did the experiments 4 years earlier. That was disappointing that the scientific community, and I think they were told by Jeremy Farrar, by Collins, by Fauci, that they had to circle the wagons here, because if science was impugned as an etiology of this pandemic, it was going to hurt science forever. Instead of, by trying to cover it up, which I think they tried to do, and it remained covered up because I didn't think truth ever will remain covered up, they end up really hurting science.
Right.
So I think the harder thing for me, since I live in Baltimore, and at the time I had 11 grandchildren, I think 9 of which were or 8 of which were in the area, for them to see the morning Baltimore Sun that had the front page saying that their grandfather was racist, because
Right.
I immediately got classified as a Chinese racist. Now, I would argue it's more racist for the Chinese to say that the reason they got COVID is their eating habits
Right.
than it is it came from a lab. Second thing they did was the state of Maryland, the Senate and the House passed resolutions that I should be censored as a racist, and they passed. And then they went to Governor Hogan and told Hogan he had to fire me because I was his chief public health advisor at the time after CDC. And Hogan's wife is Korean. His children are part Asian. All his grandchildren are part Asian. And he
Right.
turned and told the media that he knows Dr. Redfield well and he's not a racist. All right. And on the other hand, it would be very difficult to fire him because he's my senior public health advisor and he took the job under one condition, that I didn't pay him anything. So I'm not paying him and he's helping me out. I'm not going to fire him. But it was very hurtful and they know they were lying. That's the big problem. When you get the Substack stuff, the Freedom of Information, you've read
Right.
all the stuff now. You know they know.
Right.
They you
I
know
mean,
they know.
to me, I mean, look, the evidence, scientific evidence can go one direction or the other when you're looking at whether it came from the lab or it came from the wet market. You can cite different studies, stuff like that. To me, the main evidence has always been the evidence of the cover up. You don't lie about something unless you got something to hide. I just
Right.
don't know. What I don't know is were they covering this up because they knew it came from the lab, or was it they were scared because they knew they had money going into that lab and they thought that this was going to bring scrutiny from Congress onto NIH and Fauci's funding? That's what
No,
I don't know.
I think the scientific community knew that it came from the lab. If you listen to their original analysis that was the late January, they were pretty much suspicious that it came from the lab. I think they knew that it was gonna and then they obviously knew the United States funded it.
Right.
And they know that senior scientists in the United States were key collaborators to the research.
Right.
So really it was research that was conducted by the scientific community at large, including the United States. And I think they knew all of that to be factual. I was
What do you
told that one of the reasons I wasn't included in the discussion of the group was that they had decided as a group that they were going to come out with a single opinion,
Right.
which is very non-scientific in and of itself, because science isn't a consensus, group. We don't do consensus. That's politics. And people were convinced that I was incapable of accepting a single narrative that they put out. Because when the AIDS epidemic happened, I didn't accept the narrative. They said you shouldn't diagnose HIV. I said you should. They said HIV wasn't a sexually transmitted disease. I said it was a sexually transmitted. They said it wasn't predominantly progressive. I said it was predominantly progressive. So everything NIH said, I challenged. I got
Right.
away with it because I was in the Defense Department and I had my own independent funding sources. But I would have still done it if I wasn't independent in the military. But I would have had no funding because NIH would have never funded me. So there's just a lack of openness to scientific debate. I've said many times, Paul, the problem with the whole thing, how it was handled by Fauci and Collins, in my view, and Jeremy Farrar, was antithetical to science. The greatest science that I've looked and read in the history, they have aggressive debates,
Right.
open, aggressive, transparent debates. And yet here there was no room for an alternative opinion. And whether it was Jay Bhattacharya or whether it was Bob Redfield, if we didn't step in line, we got vilified.
What do you think about the fact that a couple of these studies that make these sort of claims, which have now been questioned by other studies out there, were published in Science Magazine, which is the
Yeah.
journal for AAAS,
Yeah.
which takes in money from the federal government? I
Yeah,
mean, what do you
I
think
think
about
it's
that?
really problematic. I think the proximal origin paper needs to be retracted, period. I think it's close to fraud. The pandemic, we know, started probably in August, September, and that's been declassified, not to the full extent that I'd like to see it declassified, but let's just say it's been declassified enough for people to realize that the pandemic started in August, September. That's a fraudulent paper, all right? And it was created by scientists, I think, under the direction of Jeremy Farrar, with input from Fauci, to create a scenario that there was a scientific background that this virus came uh, from the wet market. I remember my conversation with George Gao, who's a great scientist, coronavirologist, happens to be my counterpart. He was the head of the Chinese CDC. How ironic that was. You had a American CDC run by an American virologist, and then you had the Chinese CDC run by a Chinese virologist who was also a coronavirus. I mean, you couldn't have had two better people who knew the science of these viruses running these agencies. George, this was New Year's Eve. George tells me he's got 27 cases of a new respiratory illness. It's not flu and not SARS. And everybody came from the wet market. So they're following the scenario of SARS and MERS, which was sort of an animal reservoir. And so I asked George what his case definition was. And George says it's people with respiratory illness, not flu, not SARS, who came from the wet market. I said, well, George, by definition, everybody came from the wet market.
Right.
Then why are you trying to pin this on the wet market? And I think that was a political scenario that was laid out over his head,
Right.
since clearly the Chinese government knew about this pandemic all the way back into the summer. All right. But George, I don't think, knew about it until December. Okay.
No.
And so I said, you got to go outside the wet market and look for people that have pneumonia that's not SARS and flu. And two or three, a couple days later, he calls me back and he says, we have hundreds and hundreds of cases, and it has nothing to do with the wet market.
Right.
Even the head of CDC China came to that conclusion within the first week of January. And
Right.
yet, the United States scientific community and global scientific community coalesced as a team to make an argument that it had to come from the wet market. Anyone who thought it came anywhere else. Look at that article in Science that you talked about. 27 of the most prominent scientists in our nation, in the world, signed a letter that anyone who believed that it came from the lab was a conspirator.
Right. Right. No, that was in the Lancet.
Oh, okay,
Yeah.
Lancet. That's right,
Yeah.
Lancet.
Yeah. Right.
Yeah. Again, orchestrated by Jeremy Farrar. But I mean, that was, very aggressive, unscientific. I call it a wedding announcement. It's not a scientific paper.
Right.
And I know some of the people that signed it, and they're good science. A couple of them were scientific colleagues of mine, and I know they regret signing it.
Well, one of the signers was a woman who was the former head of the National Academies.
That's right. Rita Caldwell signed it, and I know Rita very well. She was my microbiology teacher at Georgetown. And so I know Rita well, and she got sucked in.
Right. Right. I want to shift over to a completely different topic. If you go back and look at the SEC filings for Pfizer, Moderna, they notified investors that the COVID vaccine that they were trying to get through FDA regulations, they stated in their SEC filings that it was gene therapy, right? Then suddenly it's called a vaccine, and they said, we don't know how FDA is going to handle this gene therapy. Then suddenly it's called a vaccine, and then it became fact check wrong, conspiracy theory if you said it's a gene therapy, which, it was in their own legal filings for investors. How did that whole thing happen? How did we get from it, that whole thing was so weird? I'll tell you something. I don't like to get involved in vaccines, and I'll tell you why, because it's very complicated. The data's complicated. It's like any clinical trial. It's very complicated. The thing that I do know about vaccines is that you're not supposed to ask questions about them, because if you are, you're an anti-vaxxer. That's the main thing that I took away in the last 5 years.
It is interesting if you ask to talk about the side effects, like I do. Let's talk about the side effects. Oh, you're anti-vax.
Yeah.
No, I just want to talk about the side effects. If you ask about efficacy, oh, you're anti-vax. No, I just want to talk about the efficacy.
Well, it's
So
not.
you are right there. There's a lack of open debate. First is the mRNA vaccines really should not have been classified as vaccines. They don't prevent infection. And you are right, as their own filing suggested, it really should have been handled probably as a gene therapeutic, which was in a way co-opting your body through nucleic acid chemistry to become a production factory of the spike protein. Just like you could use gene therapy to become the production factory of something else.
Right.
So, and it really shouldn't have been, I think, brought in under the vaccine definition. and it's
Well,
confused a lot of the people. I tell people, I think of the COVID vaccines, even the protein vaccine that they have from China or Novavax, even the protein vaccines, I don't see them as really vaccines because they don't prevent infection. I think of them more like a medicine that you have to take a certain amount of time in order for it to continue to have effect. In the case of these vaccines, their ability to influence serious illness and death probably only it lasts for 3 to 6 months, and then it's gone. And my own view right now is there's so much uncertainty about the mRNA COVID vaccines that they should at least be curtailed. I think CDC did the right thing to move the recommendation to over 65 and not recommend it for children and pregnant women and everything else in the youngers, even though, they're going through a series of lawsuits now from these organizations that I just don't think are thinking clearly because this vaccine does not belong in children. And then eventually I would like to see the FDA, I think, at least put a warning on these vaccines. And if I was to guess, 36 months, 24 to 36 months from now, I don't think these vaccines will be on the market.
it's interesting you bring up about the spike protein because that was one of the things that shocked me when these vaccines first came online. I didn't know what the antigen was at first. I didn't totally understand everything. And then I saw what it is. It's creating spike protein. And wait, hold on a second here. How is it that it's dangerous when you're exposed to the spike protein from the virus, but it's not dangerous when you're exposed to the spike protein from the vaccine? I was like, you got to explain this to me. What am I missing here?
The bigger problem, Paul, and where I've asked the FDA to, seriously relook at this is you're exactly right. The spike protein is an immunotoxic protein that causes a lot of havoc in the human body, whether it comes from the vaccine or whether it comes from the natural virus. When I do the natural virus, for a majority of people, they get rid of the virus within 2 to 4 weeks, right? It's over. Now, I happen to believe the people that develop long COVID probably don't clear the virus. It's still hanging around, and that will be a challenge for us to develop therapeutic strategies to try to facilitate viral clearance. So you can think of it like hepatitis B in the 10% of people that become chronic carriers. 90% of people clear it, no problem. 10% become chronic carriers and have long-term hepatitis B replication. I think the same is true with COVID. Now go to mRNA. I give you an mRNA. And now your body is turned into a spike protein factory.
Right.
But I don't know how much you make of the
Right.
spike protein. And I think the FDA should require both Moderna and Pfizer to show in 100 or 1,000 people what the boundaries are and how much you make. We would do that for any drug. We'd want to know how much you make, right? Any gene therapeutic product, you want to know how much you make,
Right.
right? And then I don't know how long you make it. And,
Right.
People used to say, oh, they only make it for a few days. No, that's not true. I know people who make 6 months and longer. So how long do you make it?
There was one preprint that came out. They found it over 700 days later.
Yeah, I agree. I've seen up to a couple years. So I don't know how long you make it, and I don't know how much you make. And then the other important question is, where in the body are you making it?
Right.
And the
Right.
FDA should require both Pfizer and Moderna to answer all three of those questions in a compelling way. And I personally think at least put a warning on the vaccine until they accomplish that.
What about your own patients? 'Cause I know you treat patients. You're treating long COVID patients. What are you doing with that?
Well, it's a very serious illness. I have really two major patient populations right now. One is long COVID, which is probably 10 to 20% of the people who get COVID develop long COVID. And it's can be multifactorial in what they present with. Probably the biggest thing is fatigue, and this fatigue can be extreme. Cognitive dysfunction, and it can be quite significant to the point that I have people that have lost their ability to communicate. I have people that have lost their ability to read and comprehend. It can affect your autonomic nervous system so you can't control your blood pressure and your heart. It can affect your autonomic nervous system so you can't control temperature regulation. It can have an enormous impact on your gastrointestinal tract. I've seen patients with severe peripheral neuropathy, joint pain, and I've seen people with a very unusual syndrome where the veins of their body are weakened to the point that they can't stay open under the pressure of an artery, and they develop what I call pelvic vein compression syndrome, and they can't return blood to their heart. And we need to put plastic stents in their pelvic veins to keep the blood going back to their heart. So it's huge.
Right.
And most of these patients are quite ill that I see. Many of them have lost their businesses, their jobs, etc. It's frustrating because most of the medical community tells them it's not the vaccine, it's in their head. My
Right.
original patients, most of them all came, whether they had long COVID or vaccine injury, they all came via psychiatry because the medical community said they couldn't have this doesn't exist long COVID, but it's very real. I Depending on it, most of the patients I have, I educate, I teach them about their illness. I give them the hope to understand that this will get better. Most of my long COVID patients get better in about 3 years, 3 to 5 years. The vaccine injury patients seem to take longer. There are a number of off-label treatments that I do use. One of the things that people don't realize, long COVID is not a lung disease, it's a blood vessel disease. And one of the things that patients develop is microcoagulation all through their body. So I do have a number of patients that have severe microcoagulation, very small. Like just think of it of having crud in your veins. I put them on triple anticoagulation, and they seem to improve over the course of a year or two. I have other patients with severe cognitive dysfunction and sort of a pro-inflammatory problem where I treat with actually some old age drugs that we used to be the world's experts on, Maraviroc and rapamycin, combined with a very old drug called probenecid. And what I do that for is I try to change their body's position and move them from a pro-inflammatory response to a more neutral response. If I can get them,
Why do you think that, like, you're getting them from psychiatry? What is it about people being long-term injured by either by the virus or by the you're not supposed to say that they're injured by the vaccine, although we know there's a lot of these long COVID, we're calling them long COVID, but that are actually vaccine injured. What is going on inside US medicine that they don't want to admit or even think about the
I think the real
possibility that
issue,
there's people
Paul,
who are
is
hurt by the vaccine?
there's not a simple test for them to confirm it. So these patients come in with very vague complaints. Many of them don't follow a pattern that we've been taught. All right. And so it's the simplest thing for the doctor to conclude that it's psychosomatic, that it's not real. Now, there's a couple times that that's harder for them. Like I have one patient who's a prominent professor here in Baltimore, mountain biking all through Colorado, very healthy person in her late 40s, gets COVID, and then 4 weeks later, she's bedridden. She had to live on a stretcher for 6 months. She couldn't get up at all and control her blood pressure and pulse. So when I said she lived on a stretcher, I mean 100% of the time, laying down. And fast forward now, 3, 4 years, she's totally normal.
Right.
I didn't do anything for her other than support her, help her, tell her I thought she was going to get better, tell her I understand what's wrong with her. She has autonomic dysfunction that's precipitated by spike protein. I don't know how to make it better, but it will get better over time. Let's just pound through this. And today she's totally normal. She published her first book on Beatitudes. She's doing great.
Right.
But I think in general, it's psychiatry and less so today, thanks be to God. But in the early days, and I've been doing this for 5 years now, in the early days, patients would go with these complaints of fatigue, complaints of cognitive issues, and the medical community would decide that it was psychosomatic, that
Right.
there's no test. And maybe that's an advantage that a person like me has that, there's about a dozen of us in the country right now that I consider real experts in long COVID. And, if you come and see us and we tell you you don't have long COVID, you probably don't have long COVID. If you come and see us and we tell you you have long COVID, you probably have long COVID. And we've had to battle it with the insurance companies because, I remember I saw a very prominent person yesterday. I'm not going to name his name. I had lunch with him, that's tied into the administration, a key advisor. And the first thing he says to me, he says, Bob, do you think this long COVID's real?
Really?
Yeah, first thing.
In
Didn't really think,
2026.
well, you think this is real? And
Uh,
then and do you think COVID's still a problem? And I said, well, we lost 1 point. I said, we're losing 208. Last time I looked at the CDC, they say we're losing 285 people a day. I consider that a pretty significant problem. I
right.
think it's less than that personally. I think we're probably losing more like 50 to 100 a day, but still, it's a big problem.
Right. So I have one last thing I want to go over. This is the last paragraph of your book. And what you say is the days of believing authorities because they are in an authoritative position are over. The way to convince people to follow recommendations is to provide evidence that the recommendations are not arbitrary or politically motivated, but based on science. We need to provide context. We need to admit when we are wrong. We need to be willing to change as the data changes. Policy recommendations are never going to be perfect science, but in our commitment to science and telling the American public the truth, we will save lives. I'll tell you something. After this pandemic, my trust in science, medicine, journals, the institutions, universities, the people I see being quoted in the Washington Post and the New York Times is just gone. It's gone.
Yeah, I think it's important, and that's why I kind of said it. The days of trusting authoritative people, it's over. And part of the reason of writing the book and part of the warning that I'm trying to put out in terms of public health is that if we're going to have effective public health in the United States, which I do believe we need, we have to rebuild public trust. And it's going to be a big mountain to climb to rebuild public trust. And rebuilding public trust, hopefully my book does some to help do that, because the first thing my book does multiple times is admit the mistakes we made.
Right.
We made all these mistakes. I wish some of my colleagues would do the same, because I think the sooner that we would just say, we made the best decisions we could, but in retrospect, we made mistakes. I mean, not accepting natural immunity, buying into herd immunity for this virus, mandating the vaccines, closing the schools, shutting down our businesses. These were huge mistakes, right? Yet that people still act like they were right.
Right.
Doing gain-of-function research in an overseas laboratory that didn't have containment capacity to do the kind of research they were doing. The Wuhan lab was doing this research. It's now declassified. They were doing that research under P2 conditions.
Right.
And what I'm waiting for, the declassification, they have declassified the first 3 people that got COVID from that laboratory. What they haven't declassified is their names and the exact experiments that they were doing.
Right.
And I think if they did that, everyone would say, oh my God, wow, those are the people that got infected first? Wow. So this is where I'm anxious, and I think Radcliffe will get there. I trust John Radcliffe. I think he's superb. I was going to write him a note asking, because he told me he thought, within 3 months or so, all the intelligence agencies would redo their analysis and they'd all basically come out that, it came from the lab. That hasn't totally happened. Some of them have. But I will say, it's a big job running the CIA, I'm sure, and he's got a lot of issues. But John's an honest man, and one of the things, John, if you go back and look at his testimony, when he testified, the one before him, he testified, the one after me in the Nordstrom groups, John basically said, based on data and common sense and our intelligence, there's only one conclusion: this virus came from the lab.
Dr. Redfield, thank you so much for being on, and I hope you have a great day.
Yeah, thanks, Paul. God bless.